Okay, let's go ahead and get started. Again, thank everyone for being here. This is the last session of our program, but certainly not the least important session. Again, we're very pleased and honored that PCOR is with us today. This session on patient-centered kidney disease care, how to change the status quo, that's what we're going to talk about. PCOR's mission, Patient-Centered Outcome Research Institute, known as PCOR. The mission is to serve you, the patients, through directed research that includes your viewpoints and the use of your tax dollars to do so on your behalf. One goal is to provide comparative research that shows the difference between the outcomes and cost of care. And we're very pleased that they've made the journey here today, along with my colleagues up here who will talk about a variety of topics related to research. I think you'll find very, very interesting perspective. It's a clear signal that of our desire of their leadership and their staff to reach out to constituencies that they were charged to serve through research, meaningful and reflective of your concerns. AAKP, through its Medical Advisory Board, the board in general, and our members, we have actually been involved in every single one of the research activities related to kidneys. And we look forward to continuing on and expanding that capacity. In that sense, I think PCOR started about 10 years ago? 10 or 11 years ago, okay? So what does that mean? It means that those who are involved in PCOR grants knew from the beginning that in order for the grant proposals, co-sponsorships, applications, and studies to be relevant, they needed to include patients and members of the largest, most independent kidney patient organization in America. This morning, this is time for you to hear how your voice can be heard, already has been heard, and will continue to impact the studies. I'm going to introduce the panelists, and then they're going to come up and give their presentation, and we will have some questions and answers after that. And Diana, or in terms of the time, we're going to leave it all to the good judgment of the panelists, but Diana's going to double check it. Okay, I will start with Dr. Lee to my immediate right here. She's an AAKP board member, professor of medicine at Emory University, and chief director of Emory Dialysis. She is a nationally renowned expert in hypertension, and her clinical research and interests are in hypertension, CKD, and dialysis, and she serves as the Emory principal investigator for the National Institute of Health Study, African American Study of Hypertension and Kidney Disease, and the National Medical Spokesperson for the National Kidney Disease Education Program, Dr. Lee. To her right, we have Greg Martin. Mr. Martin is the Deputy Chief Engagement and Dissemination Officer for the Patient-Centered Outcomes Research Institute, PCOR. He assists the Chief Engagement and Dissemination Officer in facilitating the integration of communications engagement, training, and dissemination activities across the department and organization-wide. Then we have our own Dr. Terry Brown. Smile for him, Terry. She's also an AAKP board member and assistant professor for the University of South Carolina. She has a master's in social work and a PhD, and she started her social work career in dialysis, working at facilities across the country. Much of her research looks at how we can help patients, particularly underserved patients, get a kidney transplant. Among her current projects, Terry is currently co-investigator on a PCOR grant, Prepare Now. Then we have at the far end, Kevin Fowler. He is an AAKP board member, an AAKP ambassador for the state of Illinois, and a preemptive transplant recipient. He's a healthcare executive with over 30 years of life science experiences in pharmaceutical organizations, both commercial and research and development. Kevin has a deep passion for patient advocacy, patient engagement, and has participated in as well as consulted for a number of research projects, including PCOR grant. And last but not least is my good friend Suzanne Ruff. She's an AAKP board member and freelance writer for the Charlotte Observer. She is also a published author of the nonfiction book, The Reluctant Donor, a must-read, and contributor to the Chicken Soup for the Souls book. Suzanne is from a family that for 5 generations, has been devastated by polycystic kidney disease. She's the only one of her parents' children that did not inherit PKD and went on to be a living donor to his sister Joanne. Suzanne is passionate about raising awareness of kidney disease and has participated in a number of research projects, including stakeholder co-investigator for the previously mentioned PCOR Prepare Now. Ladies and gentlemen, I'm going to turn it over to the panel and look forward to getting some exciting information about research, and you'll get it, as you can see, from several different perspectives. So hold on and get ready.
Good morning, everyone. It's a pleasure to be here. I've really enjoyed this meeting and hope you have. And I think this is a very important session to talk about how you, the patient, needs to be involved in research. And I think this slide sort of says it all, really. It's your life plan, it's your life, and that's why you need to be involved. And we know that there are several aspects of the whole journey as a kidney patient, from pre-dialysis to transplant, in some cases back to dialysis, and different types of dialysis. And so these are all important journeys, and you really need to have a say in your outcome. This slide is just showing you that ESRD is really, unfortunately, not going anywhere. It continues to increase. And you can also see here that the second line is patients on hemodialysis. So that's the majority of patients who have kidney failure. And then at the very bottom are the patients either on home dialysis or with transplant. And so we have a long way to go when we talk about improving not only outcomes, but improving choices of patients to get the appropriate treatment. This slide, I think, is also important, and it just looks at the whole spectrum of the renal disease continuum. And so I know we have some patients in here who have CKD, they're not on dialysis. And hopefully you are continuing to learn ways to prevent you from going on dialysis. But you need integrated care before you start dialysis. And once you get to dialysis, again, you have all these different options. Obviously, we know we've had several sessions here about transplant. That is going to be your best outcome as far as longevity of life, et cetera, quality of life. And then, so what is a CKD life plan? And really, it's a roadmap, and it's to extend your quality of life in the time that you have. It anticipates risk, it considers options, and structures decisions for the long haul. And I think this is an important quote here. It is just not about survival, it's about surviving well. And so when we talk about steps in the life plan, the first thing is to discuss this with the patient. Why is this important? And I have highlighted, and these are the ones that we're going to focus on throughout the rest of this session, is ask the patient what their goals and priorities are. discuss patient actions that can improve outcomes. So again, it's putting the patient at the center of whatever you're doing in prescribing therapy for patients with kidney failure. Now, we know education is very important. That's why this meeting exists, and I applaud AAKP for their efforts in trying to get patients educated. And so we know clearly from the literature that if a patient had the benefit of going to a pre-dialysis education class, that their outcomes once they start dialysis are much better. And so this is looking at patients who attended pre-dialysis education and those who did not. And you can see for hospitalized days, this is a huge difference. 96 days versus 347 days, sort of the average number of hospital days for the patient group, and even length of stay in the hospital. Dialyzing with temporary catheters is much less if a patient is educated before dialysis. So again, the patient needs to be involved in the decision process to have better outcomes. Now, this is a slide, I just like to show this, and it's something I'm sure most of you have seen before. And we know that patients on dialysis have high rates of death and cardiovascular disease. And this just shows you the blue is the general population, and these are ages. And you can see as you age, of course, your risk of death increase. But in dialysis patients, whether you're young or old, etc., you have much higher rates of death. Obviously, they increase as you get older as well. But it just shows the big disparity and gap in between cardiovascular disease and death in our population. Hence, we still need more efforts and research and ways to improve clinical outcomes. Now, this is a slide, this is just kind of in a nutshell. We had a lecture yesterday, I think many of you, some were there, where we went over the lab values in dialysis patients. And, you know, these are all the things that have some relationship to heart disease. And we talked about the importance of getting those numbers to goal. So what can we do to improve outcomes? And how can we get the patient more involved? What I'd like to do is just talk a little bit about what I have done at my institution at Emory and what some other programs are doing. And throughout the session, you'll hear more about other efforts in engaging patients in research. So one of my big things is a dialysis patient goes to a unit 3 days a week. They're really a prime setup for intervention and things to improve outcomes. And so one thing that is recommended by KDOQI is that patients on dialysis get screening echocardiograms to evaluate for heart disease. And, you know, we can order this and send the patient to the hospital. They go to dialysis 3 days a week. They don't have much time to go to extra appointments. So what we're doing is we're bringing the echocardiogram machines into the dialysis unit. And we're actually doing them while they're at dialysis to make it more convenient for them. The other thing is a lot of the leading cause of patients on dialysis is diabetes. They also don't have as much time to go to the doctor to get checkups. So why not bring that care to the dialysis unit? So we're performing diabetic foot checks. We're bringing dialysis educators into the clinic to help patients improve their control. The rest of what I'm going to talk about is relationships of increasing patients' awareness about home dialysis, what we're doing in that respect. I'll show you data that show that about 10% of the nation is on home dialysis. I know there's lots of home dialysis patients here. But But at our institution, we have about 20% of our patients on home dialysis. And then lastly, I'll talk about some focus groups, and then there'll be more discussion about that later, and what we've learned from those groups. This is just to show echocardiograms that are done across the U.S. And as patients are on dialysis, there's an increase in need to check our echocardiograms, but it's still not 100%. It's about 50–60% of patients actually get these done. Now I want to talk about, it is not just about lab tests, it's not just about echoes. All of these things are very important, but it's not just about that. It is about the patient and their priorities and their perspectives, about their quality of life. Are they able to have a social life? Can they participate in their family, their children, going to their activities? Can they stay employed? They want to feel better. They don't want to feel so bad when they go to the dialysis unit and all they can do is go home and go to sleep and they can't do anything. Certainly they would like to be able to get a transplant. And they want to live as long as they can, but remember, it's not just about survival, but it's about surviving well. I just have a couple of slides on things that we know from the literature about home dialysis. This is for home hemodialysis. Next stage, the Freedom Study, some of you may have participated in this. This is the average recovery time of a dialysis patient, almost 9 hours after they get dialysis. So, you know, they go to the clinic 4 hours. It's really the whole day is gone pretty much, right? But if you do home hemodialysis, that reduces to about 1 hour post-recovery time. So I have a patient that was on in-center dialysis. He went home and his wife said, "Dr. Lee, why didn't you put him on home dialysis before? He's out doing all this yard work now." And he wouldn't do anything before because he was tired. He was being drained. And so these are things that we really need to, I think, focus more on with our patients. Depression, that is certainly a big issue in dialysis patients, significantly reduced when they changed from in-center to home. These are all the benefits of blood pressure, of being on home, which I think are obvious. I'm not going to go over those in detail. I just wanted to show you some of the work that I'm involved with in trying to increase utilization of home. So first of all, you need to examine where the issues are in order to know how to improve it. And so we published this a couple years ago in PDI, peritoneal dialysis, and we just wanted to look to see if there was any racial disparities in dialysis, especially home dialysis. And you can see here, this is for PD, which is the most common form of home dialysis. 11% were white, 10% Asian, 8% Hispanic, 6.6% African American. And this was the nation as a whole. This is just looking at the whole state and interstate variabilities. And this is for white patients. The Southeast had the highest number. We're in the Southeast. I think we're doing a pretty good job with increasing use of home dialysis, but there's still disparities, especially according to race. This is the African American cohort. And this yellow is less than 0.6 or 40% less likely than the white patients on the previous graphic that I showed. Just quickly, because I'm running out of time, it's interesting that if you ask a doctor, a nephrologist, or a nurse what kind of dialysis they would want to do, it's always home. This is 90%. Only a few would choose in-center. So the question is why aren't we getting more patients on home? Why aren't we recommending that to our patients? After all, there's no place like home, right? With Dorothy and the Wizard of Oz. So as I start to close, research needed in dialysis in general, but in particularly home dialysis, we need to understand the patient characteristics of who chooses home. Why are some patients not recommended to do home? We need to have patient advocates for home dialysis. I know there's lots of you here, and I applaud you and encourage you to keep doing what you're doing. We also need to educate physicians and the healthcare personnel for why aren't they recommending more home dialysis. And we need to have more patient focus groups to understand all of these interactions. I just wanted to show you a couple of things that we're involved with. This is patient and provider values in end-stage renal disease decision-making, bridging the tensions. So this is when they did surveys with patients. And I wanted to just read, I only have 2 more slides. I just wanted to read some of the things that some of the patients said. They said that one patient complained that in weekly clinical meetings held while patients were dialyzing in their chairs, about 6 feet apart in an open floor plan, I could hear pretty much the same thing with every patient down the line. It was pretty much the same kind of drive-by assessment and move on to the next patient. And the next in a one-size-fits-all approach. And so our patients want more from us. They want, more individualized attention. And it's not just a factory, so to speak, of patients where you're spending a couple of minutes with each patient. So they really want more from their care. This is another statement. I believe providing quality care goes beyond dialysis treatments. It is about looking at a patient as a whole person with physical and emotional ups and downs like anyone else. Dialysis has a huge impact on patients' quality of life and livelihood. I believe it's crucial for mental and physical health to join support programs. And so with that, I will conclude. This is the slide I showed earlier, the life plan for a patient with ESRD, and in the middle is the patient. And that's what I want to focus on, is that they need to be involved in all of this transition of care if we want to have the optimal patient outcomes. Thank you very much.
All right, class, so if you'll open your textbooks to chapter 12, we might be able to be out of here by 6, I'm hopeful. You know, you wanted a short presentation, and Lord have mercy, they sent you little Gregory. So I'm going to do my best here. Thank you for having me. I'm delighted to be here. It's always nice to come and meet with the different patient groups that are out there and across the country. Right now, frankly, I always have a tough time sleeping in a bed that's not my own. I finally made it to sleep about 3:30 down the hallway from that massive wedding party last night. And fortunately, housekeeping was nice enough to set my alarm for 5:45. So you always got to thread that needle of too much coffee or not quite enough. And I think I hit the not quite enough mark this time, so I might be speaking a little bit slower. Tell me to pick it up a bit if you need to. But let's talk a little bit about what we're doing at the Patient-Centered Outcomes Research Institute. So PCOR, it's a strange acronym, it's a mouthy name for an organization, and we've tried to live up to every single syllable of that name. Patient-Centered Outcomes Research, and we're an institute for that. So about us, we are actually an independent nonprofit. We're solely funded by the federal government, but we sit outside the federal government. Uniquely, we're a 501c1, so how many of you love the tax code? How many of you love talking about it? Well, there's me. I mean, I live in DC. This is parlor games for us, but C1s are rarely used entities. It's an organization that's authorized by Congress but can solely receive federal funding. So the only funds that we get come from your tax dollars. As a nonprofit, though, we're guided. and governed by a 21-member board of governors that represents all sectors of the healthcare system, including patients, caregivers, family members, private payers, public payers, clinicians of all stripes. And we were set up to fund comparative clinical effectiveness research. So if you think about all the agencies that fund research, there's NIH that's doing great work on basic discovery, basic bioscience. There's the FDA. Chef O was having some concerns on the food side, but on the drug side and the device side, they do a lot of work to test the efficacy of new products, new devices. So does the darn thing work? Starting with phase 1, taste it and hope it doesn't hurt you, all the way up to phase 3 with does it work in a population. Then there's PCOR, CERs for that post-market space. Things have gone through the basic bioscience. They've gone through the regulatory approval to get into the marketplace so that way patients can use them. But that leaves a lot of questions. How many of you have been presented, or how many of you have family members that have been presented with options and you haven't quite known which one is best for you? See, all of this research, all that great research that we've been doing for years hasn't answered this basic question. What does it mean for me? I'm a patient. What does it mean for me? My dad's a patient. What does it mean for him? My wife's a patient. What does it mean for her? My kids are patients. What does it mean for them? My friends are patients. What do these options mean? That's what we're set up to find out. Look at these different interventions. Look at pill A versus pill B. Look at system design A versus system design B. Look at delivery A versus delivery B. Shared decision-making models. All these different things come together because people want to know what is best for them. What can I reasonably anticipate will happen to me given my preferences, given my situation in life, given what I want out of my life? You need that information. So comparative clinical effectiveness research in the simplest formulation, it's A versus B. Sometimes we do A, B, C, A, B, C, D, E, the whole alphabet. I don't think we've really gotten up to G yet, but we've done quite a few along. And it's to inform these important decisions. But we fund patient-centered outcomes research, which is a form of CER that makes sure that these important patient and stakeholder considerations are there, that it investigates, again, what works for whom according to their circumstances. And it's to inform better decisions. So if you look here, these are some questions that we've had. I've begun dialysis treatments while I wait for a donor. My doctor believes that I'm depressed, but he couldn't tell me the best way to treat my depression in conjunction with dialysis. Which type of therapy or antidepressant would best help me? It's a very important question. It's not necessarily pill A versus pill B, but intervention A versus intervention B. It may be a multitude of different pills with or without a combination of different therapeutic approaches. Healthcare is complex. People are complex. Biology is complex. We got to get answers, and this is how we get them. But we can't get them without patients. We can't get them out without clinicians sitting at the table together. The life cycle of developing patient-centered outcomes research includes identifying the topic and then refining it down to a specific question, conducting the study, analyzing the results, and then, importantly, dissemination implementation of findings. How many of you want to pay for research that gets published in a journal, which is lovely, but then sits there on somebody's shelf for the next 20 years? Sad trombone, wah, wah, no. None of us are really looking for that. We're looking for information. Dissemination implementation isn't just publication. It's not just presenting a poster. It's about getting it to the hands of the folks that know how to use it, that know how to deliver it to the people that need it. And that's why I'm happy to be here, because organizations like AAKP are so critical for that dissemination question, critical for that implementation question, and also critical at the very beginning of this process as well there. Identifying the topics and refining down into the appropriate real-world questions. And there's this difference, this distinction that needs to be made between patient-centeredness and patient and stakeholder engagement. You can be very patient-centered but have squat-o patient and stakeholder engagement. Likewise, you can have great patient and stakeholder engagement but not have the patient anywhere at the focus of it. So patient-centeredness, does this project answer questions that matter to patients and their caregivers? Patient and stakeholder engagement, are they there at the table with you through that entire life cycle? We're not talking about an endorsement letter saying, this is a nifty study, we think it's great. It's about inviting them to the table, Having these communities there to talk about what the real-world implications of different care decisions are, so that way you can develop a much more responsive research project. Again, to make sure that the evidence that comes out at the other end of this research process actually does matter. It actually does facilitate the uptake of the findings. And also, if you have those folks there with you the whole time, it not only influences the research to be more patient-centered and more relevant, it not only encourages that successful uptake, all of that happens because it has this internal legitimacy, this validity. In a previous life, I worked for the Family Docs, the American Academy of Family Physicians. One of the things that we always looked at, because we were constantly bombarded, like each of you are, with information, with new studies, please disseminate this, please distribute this, to help us try and gauge how much we were going to push out at any given time. It wasn't the only measure, but a key thing for us if we had to tilt the scales one way or the other with limited space. How were family physicians involved in this project? How were they involved in this study? If there was a project that had a lot of family docs there and a project that had no family docs there, we were going to go for the one that reflected their values, reflected their perspective, reflected their needs. But this is still relatively novel in research. So how do we actualize this? How do we implement this? How do we get this into practice? It's a question we got a lot at PCOR in the early days. So I've been at PCOR for coming up on 6 years now, before we issued our first funding announcements. When folks were coming to us and saying, I don't know what this engagement thing you want is, how do I do it? So we looked at successful models out there from across the world. We looked at what was coming to us over the transom in our applications, and we developed an engagement rubric to help us help the community, help researchers, help patients, help patient advocates, help clinicians understand how they can engage in research. And at the foundational level there, it goes back to those kindergarten rules. There's a great new documentary I hear on Mr. Rogers that I can't wait to see. I think like all of you, he's kind of a personal hero, someone that's greatly missed in this world. It goes back to these foundational values that everybody at the table needs to bring. Transparency, trust, co-learning, partnership, honesty. These are important things. Everybody put their cards on the table. We've done this ourselves at PCOR when we've had thorny questions that have come to us from stakeholders saying, invest in this area. We've developed large workshops. Some of them have been so large that some of my colleagues have said, why are we even doing this? But it's to make sure that everyone gets a voice at the table. And they've worked. We ask folks to come and be transparent with us. The life sciences industry, patients, clinicians, bring us your questions and let's identify what really matters in the real world. You all have expertise. Your expertise is valid. So that gets to planning the study. Then we get to conducting the study, being there throughout the whole cycle of it, helping to identify sites, helping to recruit participants, patients. That patient voice can help bring other patients in. It's about helping with analyzing the data, helping to make course corrections as the data comes in, helping to analyze the data for findings, developing the findings. PCOR, what we do is we publish a technical abstract and a lay abstract, a professional abstract. So that way, things are written both in a level that I can understand as well as in the level that Dr. Lee understands. So we have the professional and the lay. We're doing this with our final research reports as well. It's about making sure that this evidence is accessible to all stakeholders. And who are they? Well, for us, because you've got to kind of carve things up a little bit to make assessments on engagement, which is something we grade our applications on. Of course, there's patients and consumers right there at the top for us. There's caregivers and family members, clinicians, patient and caregiver advocacy organizations, hospitals, health systems, clinics, the facilities where you receive care, because that's a different perspective than the people that work in those facilities. Training institutions, public policy, industry, payers, and purchasers. Employers have a very valuable role in this as well. We use 3 major funding awards, so I won't linger on this too much, but they go from comparatively relatively small for those of us, that go to work every day. 1.5 sounds like a lot. In research, that's a decent but relatively modest sum. We have larger targeted awards that vary wildly in size and length, and then pragmatic studies, which are for up to 10 years, or for up to 5 years and up to $10 million in costs. So what have we done in kidney disease? Well, we've funded 17 CER studies at a total of about $69 million, so pushing right up on 70. So hopefully in these upcoming funding cycles we can get that a little bit higher. All 17 studies look at treatment of kidney disease. And because one of our legislative mandates is to look at subpopulations, how do these different treatments affect different groups? So that way, again, we can get to what works best for whom according to their circumstances, according to their preferences. So you see populations of interest in these studies: racial and ethnic minorities, older adults, multiple chronic conditions, low socioeconomic status, low health literacy, urban, and also one that's very rural that I'll share in just a second. A sampler of some of these: a patient-centered medical home for kidney disease. So a dialysis team usually has the kidney disease specialists and staff, but no primary care. So this one was looking at how does it work when you actually integrate into this dialysis setting the primary care physician, the nurse coordinator, the pharmacist, et cetera. So patients' input helped the research team plan, implement, and evaluate, again, from beginning to end. The results: the patients reported having a better quality of life after receiving care. And after 18 months, after a year and a half of going through this model, they also had better mental health. They felt better about their life. So patients also felt they had a doctor they could trust. They felt they had their personal doctor. And in this world, in this health system, that's really remarkable. That's really remarkable for how much we change jobs anymore, how much we change insurance, how much our insurance changes our network. To have folks saying, I feel like I have a doctor that knows me and cares. That's remarkable. This is the very rural one. We actually went out to visit Dr. Shah, who is the fellow running this one out of University of New Mexico, along with the Zuni Nation, which is way out in the western part of the state. And let me tell you, that was a long, long drive. How many folks from Arizona or New Mexico? Many wonderful shades of ochre, I gotta say. It was really remarkable. But we got out there and we visited the Zuni Nation and got to hear about how this model that was being implemented was already changing their care and making them feel better about their care. It's about telemedicine, something that a lot of folks have a lot of questions about. It's increasingly being proven to work, and we're hearing more and more from payers and employers that they want to find models that work so that way they can start paying for it. Also, this is one that I think is pretty cool. So this gets into the A versus B versus C versus D versus E. So the newer oral anticoagulants. So most of us have probably heard of warfarin. We probably know somebody that's been on that blood thinner. There's a lot of newer ones, and we don't necessarily know with these newer things quite how they work. They work well, they're effective, they're in the marketplace. That was FDA's role, remember? That was their spot in bringing it to market. PCOR is now stepping in to look at how do these work against each other, especially for people who are older and especially for those that have kidney disease. Which one is going to be the right one for you, warfarin versus some of these newer ones? So we're anxious to see and excited to see how this study turns out, because we think this is going to turn up some pretty good information. And of course, Terry, she's going to talk about her study. So I will save all of the wonderful details on that, but I believe it's for preparing patients with kidney disease for the potentiality of kidney failure, correct? A really great study there as well that we're also very excited about. That's a very important topic. So we've also funded work on data. So how much have we talked about big data in this world in the last few years? There's a lot of data out there. It shouldn't just be generated by payers, shouldn't just be generated by EMRs. Patients have a lot of data. So we funded the NephCure Kidney Network. So this is a patient-powered research network that brings together patients' data to help fuel clinical research. Now again, I want to pivot a little bit because we're a funding agency and talk about what we do, which is fun stuff. Our mandate is also to make sure that we can support those in understanding and participating in PCOR and CER, comparative clinical effectiveness research, patient-centered outcomes research, particularly patients. So we set up a track of funding awards called the Engagement Awards, and these have been doing some great work for us for helping to build capacity so that way communities, however they choose to define themselves, will better understand what it is that we're funding on the research side and how they can then be engaged in that work. Now that we have findings coming in, we're doing Dissemination Awards. So these are a little bit larger, but these are where we're looking for key partners to come to us to identify projects that they think are good and to work on developing new pathways, possibly, new vehicles for getting this evidence into the hands of those that need it. So it can be a range of different strategies. It's about increasing the reach of this evidence, increasing folks' motivation to use the evidence and apply the evidence, and increasing people's ability to use the evidence. So we're looking for folks to come to us for these applications. The next cycle, the LOI deadline, I believe, is going to be in early October. Hint, hint. And we hope that we get a good, robust number of letters of interest for that. We're also doing a lot of other cool things at PCOR. So over the next year or so, already to date, we've funded $206 million additional in research. We're going to push out $9 million more in other dissemination awards than the engagement award. So these are much more intensive dissemination activities. In June, we're going to award possibly up to $53 million in symptom management for patients with advanced illness, but also a couple of tracks on the opioid crisis. We're also going to look to fund up to $6.5 million on implementation of evidence from our major studies. So this is a separate thing from even just those dissemination ones. And we intend to issue several more of those broad awards and pragmatic study award cycles that I mentioned earlier. Other new stuff that we're doing to help better understand what's coming down the pike, we're going to establish a horizon scanning program. So what does that even mean? What is horizon scanning? I stand out there on the beach and stare into the sun like I did as a kid, which was not very smart, and now I should probably have glasses. It's not that kind of horizon scanning. That was a joke, by the way. I never actually did that. Horizon scanning. This is looking at what's coming down the pike in terms of new products, new treatments. So as I mentioned, FDA has several phases that any product goes through before it hits the marketplace. We've had some whiz-bangers that have hit the market in the last few years. If you think about some PCSK9 inhibitors, which have been started being used for primary prevention of atrial fibrillation, so it's a blood medication. There's also the hepatitis C curative treatments. These things were big, high-dollar things that folks saw coming but didn't quite have enough evidence. This is to look at those things that are going to be big things and try and get a better handle for patients, for clinicians, for researchers. We're also going to start doing summaries of new and emerging technologies, so that way we can have a better, simpler way of discussing it. So we're hopeful that in the next 6 months we'll have issued our first one of these, which will be looking at the new genetic therapies. So there are some of these that are hitting the market. One of them is for hereditary blindness, a genetic blindness condition. Very expensive treatment, but it can help people see again. So how do we weigh these pros and cons, and what's the evidence that's out there? How can we bring the totality of it together in a way that's helpful for patients and clinicians? And we're also going to develop evidence maps, because as folks step into research, it's very important to know where the research has already been done. Where are those gaps? That's what we want to do, is step in and fill some of these gaps in the evidence. So we're going to start doing evidence maps, which is a way of bringing all of those different studies together, trying to identify how much of it there is in any given area, what the strength of that evidence is, so that way we can start to identify in a very simple format, where are the gaps? Where should we be looking for the next investments in new evidence? So with that, as my dad says, quit your yapping, boy. I will quit my yapping at you. I'll be around for some questions, and I look forward to chatting with you in a bit. So thank you very much.
Thank you very much, Greg. Nope, that's not me. Sorry, should have brought my glasses up here. Oh, that's me. Okay, so I'm going to talk about a couple different projects that I've had the honor to work on. One is called Prepare Now. We have a website, we have a Twitter, we got a Facebook, I'm pretty sure we also have an Instagram. It is by no means my study whatsoever. Ebony Boulware and Dr. Ebony Boulware and Jamie Green, Ebony's from Duke and Jamie Green is from Geisinger. We talked a lot about Geisinger in our last session, are the principal investigators And I can speak for all of us to say that this is probably one of our funnest and most rewarding research projects that we work on. So this is a PCOR-funded study. It's a 5-year study. We started in 2016, and what we're looking to do is change a health system. We're trying to change Geisinger Health System, which is a health system throughout Pennsylvania, and trying to help people as they go through kind of the steps of kidney disease. So we're trying to identify people very early in the kidney disease process. We're trying to get them at that stage, give them all sorts of stuff, information, education. We do group classes, we do individual classes, we do living with kidney disease classes, we do options classes. And we also give them a special person that's going to help them kind of figure out for themselves what treatment they want and make sure that everybody in that health system knows it. So many of you probably are familiar with what's called advance directives. So it's kind of your wishes in case, God forbid, of an emergency. And every time you go to the hospital, you go to the doctor, they always ask you, do you have a healthcare proxy? And might ask you questions around that. And that's because they put it in your medical records to make sure that everybody in the health system knows what your wishes are. We're trying to do that with kidney disease because, as you all know, too often people end up just really sick in the emergency room on hemodialysis. We're trying to stop that, and we're trying to let people make decisions before it gets to the point they need dialysis or transplant or no treatment. So we started in January 2016, and we're studying this new model of care. So on this project, we have 6 patients and 2 family members, and on our project, they are what we call co-investigators. If you're not familiar with the research process, that basically is an investigator. It's considered a researcher on our team. So it was really important to us that the patients and family members were not kind of superficial consultants who we kind of put on the grant just because you need some patients and family members on the grant. We've worked with these patients and family members actually well before we submitted our grant in 2015. We started many years ago with the American Association of Kidney Patients. Jerome was still there, and they gave us a bunch of names and suggestions for patients and family members who might be interested in partnering with us on a research study. We submitted an application in PCOR. It was rejected. We kind of regrouped. Everybody still wanted to work with us, and we submitted another one, which was successful. So also, in addition to these patients and family members, we also have many kidney disease organizations who are stakeholders on this project, including AAKP, the Network, National Kidney Foundation, Medical Education Institute that does all the life options and the stuff. Circled, this is little snapshots of our whole, it's a big, big project. That's our whole research team, and there's even more people since these pictures were taken. Those encircled are our patients and family member co-investigators. So we've got Brian, who's a patient. He's a in-center hemodialysis patient at Geisinger. Shakur actually is a transplant patient who lives here in Florida. Patty Danielson, many of you might know, she's a nurse, and she's a home dialysis patient. She lives in Washington. Katina Lang is now a transplant patient. She is a social worker and now a faculty member also in social work. Suzanne Ruff is a family member and living donor. Lana Schmidt, who's not here right now, but many of you know her also, who's a board member, who is now a transplant patient. Amy Swoboda is the wife of a patient who goes and gets dialysis in center. And Peter Woods lives in Long Island, and he now is a transplant patient. He actually got his kidney disease, if you will, from being a first responder. He was a police officer in New York City after 9/11. So we've been together as a team for many years, so many years, in fact, that 3 of these people started as dialysis patients, but now are transplant patients. So I shared with you the different social media. So that's one project that we're working on. I will go back and just say, so what we do, the group of patient and family member co-investigators meets about once a month by phone. We worked together for probably 3 years before we all met each other in person. I knew Suzanne from AAKP and other activities, but there's a lot of people on our team we never even met in person for a few years after working together. And then our patient and family member co-investigators are involved in all of the different work groups. So we have a data work group, we have a recruitment work group. Then we also have full team meetings. And I will say, and Suzanne can chime in a little bit in her part of this talk, there is nothing we do on this project that is not talked about and decided by our patient and family co-investigators. Everything to that logo that you see there, how many meetings was that, Suzanne, that we talked about? They talked about that logo, the font we used, the acronym, because Prepare Now is an acronym, the colors. It was several months of meetings with the patients and the family members for them to pick out our logo and our title, pick out what it is that we're studying, what are the important outcomes that, and they came up with all sorts of things that we're measuring that we never thought of. So really, when I say they're involved in every step of our research project, I mean that. The other event that I was able to work on is a national study looking at research priorities for people with kidney disease and researchers. I co-chaired that. That was a PCOR-funded event, happened last year. I co-chair that with Derek Forfang, who I'm sure many of you in this room know, who's a patient, with the National Kidney Foundation. And we did a survey of almost 1,000 patients and their family members and about 700 researchers. And I just wanted to share this, and then we'll hear from Suzanne. So we did a survey and asked patients and their family members, their care partners, if they were interested in kidney disease research. Almost everybody, 89%, said yes. Then we asked them also if they've actually ever been involved and directly involved with a research study about kidney disease. Horribly, it's almost the entire opposite results. So despite almost everyone wanting to be involved in research, almost everyone has not been involved in research. Sadly, also, we had similar findings from researchers. So we asked the researchers if they've been involved in patient-centered outcomes research, and the majority said no, 74%. So 74% of the researchers, almost 700 researchers that we surveyed, were not doing any research that was patient-centered. And we also asked them, where are you putting out the results for your research? So typically, us researchers tend to publish in journals, and they're very complex and complicated. Even me, you know, with my PhD, sometimes I struggle through reading some of those journal articles myself. So that's not really accessible. It's not accessible to professionals who work with kidney disease patients, and it's definitely not accessible to people with kidney disease and their family members. And unfortunately, just about half of researchers are not publishing and disseminating their findings in a patient-friendly way. When we asked patients and family members what were their top priorities for kidney disease research, the biggest priority was about prevention, so preventing kidney disease, then about the biology of kidney disease, which is kind of related to that prevention, stopping kidney disease progression, Then we looked at some what we would call more psychosocial issues like quality of life, improving the treatment options, and how you make those decisions, and costs. Finally, I just want to share with you a couple comments from our patients on this survey about research. And we also heard this in an event that we had as well. You know, somebody said I was a guinea pig. The common kind of opinion is that patients traditionally have been very passively involved in research. So us researchers in our ivory towers might ask you to do a survey, we might get your blood results, but then that's about it. So, you know, we have people say you're asked to participate, but then you never hear from the study group. I know nothing about kidney research. It seems the most important decisions, research, et cetera, that affect patients leave out the patient. Another person said patients and care partners are on the outside, medical doctors and researchers are in the inside. The insiders don't want the outsiders to mess up their desired results. Finally, somebody said, my son has been on different trials, but we've never heard anything about them. It would be good when he went for appointments if he was told how he has helped these trials. So that's just a little glimpse into some of the work that I've been honored to do. And Suzanne's going to talk about her experience as well. What's that? Oh, here. You hit escape? I assume that's escape. Do you know the title? Oh, Suzanne Riff.
Wrong one. Oh, no, that's it.
Yeah, I just got to do that. There you go.
Okay. Okay, we had the chef, so I thought this was a good slide to come after our dietitian. How many of you know al dente when you just make pasta and you throw some pasta at the wall and if it sticks, it's done, right? Well, I thought this was a good slide to start with because when I was a teenager in the early 1970s, my mother and father dragged my sisters and I to a conference, a kidney conference. My mother was just diagnosed with kidney disease, and it was, I was dragged. I did not want any part of spending a day in a conference talking about death, disease, and doom. But I wonder how many of you in this room have been dragged to this conference too, if you're a caregiver or even if you are a patient or if you're still in denial. But sometimes, and I guarantee it, something that you learn at today's conference is going to stick with you. It might take a while, but it will eventually stick. I was on, as Terry mentioned, I'm a co-investigator on the Prepare Now program, and I'm going to tell you not as much about the research part as Dr. Brown told you. I'm going to tell you from a patient and a patient's family point of view. If I can figure out how to go to my next slide. The arrows, you see
Right here. Okay,
Yeah.
I couldn't see the arrow. Okay, my husband, who is sitting up here, we have 2 children, and when they whined, this was his favorite expression. And I know most of you are here because of kidneys, right? But this was his favorite expression when they were whining about something at school or at work or wherever. If you're not part of the solution, then you're part of the problem. Now, I'm not expecting any of you to go home in your garage and try to fiddle with a bunch of little electronic parts to make an artificial kidney. I don't expect you to buy a microscope and try to examine blood and look at anything like that to try to figure out why iron goes in your liver and all those things that the doctor knows that I do not know. I faint at the sight of blood, so I wouldn't want you to do that. But in the book of life, there aren't any answers in the back of the book, right? So we all have to go out and search and find those answers. And that includes a patient. You have to decide, and you're learning that today, whether or not there are answers for what you need. And
that's what you need to do, because the least utilized resource in the healthcare industry is the patient, and that's all of you here in this room. I want you to know that I hated hospitals because of my family's background. I should tell you, I'm from a large Irish Catholic family from the south side of Chicago. Leroy Brown's song, "The Baddest Part of Town," and we're pretty feisty. And I've got the wrong slide up. My mother, this is a picture of my mother in the early 70s on dialysis. She often commented that she was such a lucky duck because her brothers and sisters went before her and died before dialysis was covered by Medicare. I had one Uncle Jack, who my mom's oldest brother, who had to go before a committee, a psychiatrist, to see if he was stable enough to have a home dialysis machine brought into his home. There weren't enough machines. And my uncle, who was very feisty, very Irish, said, "What the hell do I have to go tell that man that I'm sane enough to want to stay alive?" And when he saw the psychiatrist in the room that he was at Michael Reese Hospital in Chicago in the 1960s, the psychiatrist was snoring in the chair, kind of like my husband was a little while ago. And my aunt was so afraid that my feisty uncle was not going to be approved for that machine. He was approved. They did have a dialysis machine brought into their home. They nicknamed it the Monster. They did dialysis Tuesday, Thursday, and Saturdays, and my aunt also did the wash on Saturdays, so it was washing kidneys and washing clothes day. The one time when she came up from the basement, there was a hole in the dialysis tube, and her wallpaper was splattered with blood while my uncle sat on that dialysis machine. She carefully plugged up the hole and wiped her wallpaper down, and my uncle had no idea how close he came to a catastrophe. Why am I telling all of you this, and why am I here today in this dark little room on a beautiful June Sunday? I'm here because my 39-year-old goddaughter and niece has polycystic kidney disease. And all of you here in this room are just like me. We all have a reason to invest in our care today and to help the people 30 years, 40 years from now, just like my uncle did. And I just realized that I'm the last speaker. So I could tell you about all 23 family members if I wanted to, until your eyes glazed over, but I won't do that. My Uncle Bill, he was one of the first transplant patients at Johns Hopkins. He used an experimental drug, anti-rejective drug that he was told had a great risk, and he did it. And that's why clinical studies, PCOR studies, for the patient, the family caregiver, are so critical for all of you to find out about, to learn about, to think about. When Dr. Brown turns to me in a conference call and says, "Suzanne, what do you think?" and she listens. Or when Dr. Bulwer says, "What do you think what is the most important thing to a patient?" And I remember my mother, the first thing she'd say was, "My control. Damn it, why don't they listen to me?" And one time she had a dialysis machine that wasn't working. She was a compliant patient. She was on dialysis for 10 years. She blew up like the Michelin Man, and she said, "There's something wrong with this machine." And no one would listen to her until she called her doctor, who knew my mother was a feisty Irish woman and there was something wrong with the machine. And there was. And that's what you have. Your voices will be heard if you step up to the plate and get involved. There are so many studies. You can go to clinicalstudies.org, .gov, sorry. I got it on a slide here. But you have a voice, and we're here to help you at AAKP. Don't feel like you're all alone. And I went one too far. And I hope that this morning, if you have any questions, we're all up here to help you answer any of them, and we appreciate you staying for the last session, which I think is the most important session. Thank you.
Did you want to make even some comments?
I was scheduled to speak, but I think just with the time and everything, it was just better to not try to compress 20 minutes into 2 minutes. I think it's better. I think I would just add one comment, is that if you look at what the organization, why policy is important, the Dialysis Patient Demonstration Act, the significance of that is that maintains the status quo. And that needs to be opposed by every person in this room. And what we all need to work towards, early detection, coordination of care, early interventions. I can't tell you how many people I was just talking with Janice today, 14 years on dialysis, and she had proteinuria that wasn't treated by her doctor. I can't tell you how many times I hear those stories, and it makes my heart break, because I never was on dialysis. So I think that, you know, what at the end of the day is going to change things, you've got to know the policies, and you've got to support the policies that are in your best interest. As I told one of the patients here who was working for dialysis patients, citizens, don't carry the water for someone who's working against you. It has to start here, and it has to start now, and it can't let up until we get what we want. So that's my 2 cents, my talk, another day. So.
Great, thank you. And the one thing I do want to make sure we mention, and we probably all thought it would be in somebody else's slide, a great way to get involved in this area is to become a PCOR ambassador. How many people in here are a PCOR ambassador? Okay, so just, I am too. So just a very small handful of folks. So PCOR, actually, do you want to talk about what an ambassador is? I'm like, you can certainly talk about it better.
Is there anyone from PCOR here? Anyone? Anyone? No, we actually have a few things that we've put together to try and help folks, particularly patients, caregivers, family members, engage in research, one of which is the Ambassadors Program. So early on we had very enthusiastic, very energized patients that were coming to us, and they said, we want to be your ambassador to our community, to other communities, to help spread this gospel of patient-engaged, patient-centered research. So we created this program in response to that. It's a way for folks that really want to learn more about PCOR, about patient-centered outcomes research, about our funding opportunities, about tips and tricks and methods for connecting with researchers, ways that you can work together, ways that you can share your personal story. That's what this program is for. We also do an annual workshop at our annual meeting, which is coming up at the end of October. So if any of you are interested in coming to DC, I highly recommend that. It's going to be fabulous.
And something to add too about the scholarships that are available. I don't know if you want to speak to the scholarships that.
We're still deciding how many scholarships are going to be available.
But the fact that they do exist.
Yeah, there will be scholarships
I think
available.
it'd be nice for people to understand what that is, and because I participated in one, I don't know if Dave did, but it might be nice for people to understand what that is.
Well, at the Ambassadors Program, we recognize that, not everybody has, the means to make it to DC for an annual meeting every year. So we set up a scholarship program to provide travel support funding. It's typically on a competitive basis. We try and get a blend of new and returning attendees, and also try and blend with a heavy emphasis on patients, families, caregivers, but also some of our clinician ambassadors, also some of our researcher ambassadors, et cetera. So that way we can have a broadly representative and diverse group of folks there at the workshop to engage with each other and engage with us, because we learn a lot from it. Some of the other opportunities that I highly recommend, number one, if you want to learn more about the methods of conducting comparative clinical effectiveness research, we have a methodology committee that issued a methodology report. Methods are very important. We grade very hard on this in our applications. So the methodology report itself, if you want to give up that Sominex, boy howdy, grab that report and cuddle up with a comfy pillow. What we did, though, is we developed continuing education units. So if you're a clinician and you need CME or CE units, you can go there. It's free. But also it's oriented towards a lay audience as well. I did it. So, if I can do it, you can do it. So get on there. They're video, audio enabled. You can step through. You can learn just, some of the basic stuff to be more conversant in the methods that your research colleagues are going to be working with. And I say that as colleagues. You're on equal footing at PCOR. in the research team. They're going to be your colleagues. We also invite folks to apply to us to be merit reviewers. That's the side of our process where folks review the applications that come in. Every application that comes to PCOR is reviewed by 2 researchers, at least 1 patient, and typically 1 other of those healthcare sector stakeholders, plus 1 methodologist. That's on the getting funding side. On the you've got funding and your research report comes in, Terry, be mindful, when you go to peer review, we peer review every final research report that comes to us. So that peer review process also includes 2 researchers from the area and at least 1 patient, if not 2, plus a clinician to take a look at that report and make sure that it makes sense. Because we publicly report everything. Every single study we fund is going to have the findings available. They're going to be translated by our translation center, and we ask and require that all of our awardees, all of those researchers, report back the findings, because as you said, you know, it's just a good courtesy to report back to everybody that took the time to participate in your study to let them know what happened with that study. So, whole different range of opportunities that we try to make available, try to make them as cheap as possible, if not free. There is travel support for all those merit reviews. There's a stipend support as well. So we try and make sure that we can make this as easy as possible for folks, because we do appreciate the giving of your time, because this is not something that's built into the average person's day, like a person who's an academic-based researcher. So.
Great, thanks. So I don't know if there's any questions or comments. We've got a couple minutes for questions or comments. I will say that Brian, who is the patient co-investigator on our study, who's at Geisinger, he's won the scholarship. He's an ambassador, and he's got the scholarship and has gone to the national meeting twice and has been reviewing a couple applications as well.
Great.
Any questions, comments?
I got a question for other allied healthcare professionals, PTs and OTs, surge techs, anybody who takes care of kidney patients. I think that might be something we might want to open up and maybe have some discussions from those people as well, because they're an extremely important part of it, especially after transplant care. Well, some of us during the transplant itself. The other thing is, I forgot what it was. Oh, well, you're off the hook.
Well, no, I'd echo that note about the importance of engaging all the relevant stakeholders. We want to see those folks that are proximal to the care right there at the table as well, because all of those varied perspectives represent the real-world experience. All those different lenses are important to make sure that things move appropriately. One of my favorite examples was a study protocol that was being drafted, and a study site was actually taking the time to run it through their staff, which was great because one of the medical assistants looked at the protocol and said, this ain't going to work. This is not going to work with our workflow here. We can't operate with this study protocol in place. A medical assistant came back and was able to change the study protocol to better match the study site. It's important to have every professional there, so that way you can have a well-rounded, real-world perspective.
Great. Any other questions or comments? I will just say that on our Prepare Now study, we actually have Council of Nephrology Social Workers as a stakeholder. We have the Renal Physician Association as a stakeholder. And our very, very large research team is entirely interdisciplinary. So, and PCOR really does look at and consider stakeholders to include these different interdisciplinary professionals. With patients and family members at the center, absolutely. Great. Well, we thank you all, and we thank you all. Are there any closing remarks for the meeting? Thank you.
Just a couple of quick high notes. So we purposely structured our meeting this year so you got a blend of public policy from top experts in Washington who are on the side of action, how legislation gets passed or opposed. What we also did is made certain that it was content heavy, so you can see different things on the nutrition side from this morning to other issues that are developing. We put up innovation on there, and as you can see, PCOR is working on aligning itself with where innovation is going to be over the horizon. AAKP has had the great fortune for several years now to have an innovations panel where we have the top researchers and those who are actually going to produce the new devices here in front of you as patients, and they have already reached out to you, and they're incorporating you in their own corporate focus groups, which we appreciate your participation in. So as we start planning for next year, and the staff is very committed to it with our new full-time executive director, Diana Kleins, we'll be interested in your insights after this. Please fill out your surveys. We'll want to know what city that you're thinking about going to. You'll see some separate information about that. But in the sense of live time, you have a combination of policy, you have a combination of disease knowledge, and you've had fantastic social media skill training. One of the presentations here that happened the other day was a discussion of a piece of legislation called the Patient Demonstration Act. Now, as it happens, good allies sometimes can disagree. That piece of legislation is actually being debated today in Chicago at the American Medical Association. And so what you saw up here was AAKP, the American Society of Nephrology, the entire transplant community, and also now we've been joined by the American College of Surgeons. We've been joined by all of the nonprofit kidney care organizations. We've been joined by the Rogerson Institute. We've been joined by DCI. And we have a board member and other folks that are out there today in Chicago that are talking about this. So if you want to put your skills to use, it's totally up to you. But on social media right now, if you go onto AAKP on Twitter or Facebook, you will see a post that sends a message to the AMA, the American Medical Association, the medical community, where you have an opportunity to give your patient voice to what they're deliberating about the Patient Demonstration Act. We are opposed. If you like that, like the post and share it with your friends. Every individual here, if you're on Twitter, you have 798 on average that follow you. If you're on Facebook, you have several hundred. You can send a message to thousands of people right now. AAKP combined has a reach of over 5 million on social media right now. And you can trust us, we'll be using that. We're not always against things. We hesitate to do that. It's the first time in 10 years we've opposed a piece of legislation. It's difficult to do it. But when we do it, we are very effective. We need you to help. Yeah. On the optimistic side of things, there's so much more that holds us together as a community. And I think the best spirit of that you saw with our friend Bill Murray, big heart, big voice, and looking out for people who aren't here today and who may never join us at a meeting, but their stake is in your hands. And so to the researchers, to the policymakers, to the innovators, we're all trying to go in the same direction, but it all comes down to you and how active you are. We're one platform. There are many different organizations you can join. We're honored that you joined us. We're honored that you're here and took the time out of your summer to be with us. So thank you very much on behalf of AAKP.